Welcome everyone. Thank you for tuning in. My name is Basem Elbarouni from Winnipeg, Manitoba, north of the border. I'd like to thank CVI for this opportunity to talk to you about CTO PCI equipment update. This is my conflict of interest. I'd like to talk about updates in wires, microcatheters, and guide extensions. As you can see from this slide, it's important to understand where wire falls in terms of the different wire categories. These are the 7 wire categories, and it's important to be familiar with at least 1 or 2 wires from each category. These are the categories that have updates that I'd like to mention. The polymer jacketed soft tapered wires are designed to navigate and find microchannels within the occlusion. The Fielder XT has been the flag bearer for this category. The major update in this category is the adding of a composite core to the Fielder XT, generating the Fielder XTA and Fielder XTR, A for antegrade, R for retrograde. The Fielder XTA tip is tapered to a 0.010 of an inch with a load of 1 gram force. The Act 1 dual core increases the steerability significantly compared to the original Fielder XT. The Fielder XTR has a similar design to XTA, but the tip is actually softer and is softer than the original Fielder XT. I personally use the Fielder XTA for microcatheter probing now, but I still have the Fielder XT on my shelf for knuckling. The Gaia wires introduced us to a newer category of wires, the intermediate force directional wire. With the conical shape and the composite core, this was extremely steerable wire that could traverse long segments of occlusion as long as they were not calcified and cross into the true lumen. There is a bit of a learning curve with the Gaia wire using the direct deflection and directional control. The wire would be advanced until it deflects, rotated, advanced further, rotated, and henceforth. Once this wire is mastered, you'd be able to cross long segments of occlusion as long as you're aware of the course of the vessel with higher success. And now a newer generation of the Gaia wires is available, the Gaia Next. The major addition is the X-strand coil, which is formed of multiple small filaments weaved together instead of a single conventional wire coil. This decreases the breakage risk and improves resistance in case of trapping in a lesion. Furthermore, the tip is made more conical, increasing penetration force. Intermediate penetration polymer jacketed wires are major players in the field of CTO PCI. Pilot 200 has been the flag bearer for this category and has been extensively used in the field. Radar wire is a competitor made by Telflex that is more radio opaque and seems to have somewhat better steering and penetration. The new addition to this category is the Gladius Mongo wire. The Gladius wire has a dual core, increasing steerability. It has a tip load of 3 grams, slightly less than the Pilot 200. What's unique about the wire is how it knuckles. The upper video shows a classic knuckle of a Pilot 200 wire, while the lower video shows a knuckle of the Gladius Mongo wire. The knuckle seems to be controlled at a hinge point, doesn't wreck the wire. Once a CTO segment has been crossed by a knuckle maneuver, the wire could be straightened out and used as a penetration wire as well. There has been an evolution or change over time on collateral crossing wires. When I first started doing CTO PCIs, Fielder FC was the wire to use. The Xeon wire came along and had a much safer tip and much more steerability. Currently, however, I alternate between the Xeon Black or SU003 wire. The SU003 wire is a soft tip wire at 0.3 gram force with a rope coil surface, allowing extreme flexibility and trackability. It is the preferred wire for epicardial collaterals, especially in tortuous ones. This example shows an epicardial collateral. It is by no means the most challenging one, but I wanted to show this to demonstrate the way the wire tracks and finds its way through, usually with very minimal manipulation. The Xeon wire is, the Xeon black is essentially the Xeon wire with a polymer jacket on it, making it more lubricious and trackable. This is my go-to wire now for septal surfing, and I find it finds its way with more ease due to the hydrophilic coating and polymer jacket. I don't have any major changes to inform you regarding single lumen microcatheters. Due to its smaller crossing profile, the Turnpike LP has become the most preferred retrograde crossing microcatheter. Now, Corsair has made a competitor called the Corsair Pro XS with a slightly smaller crossing profile. However, the use of dual lumen microcatheters has increased in the field of CTO PCI. This is not new technology. The Teleflex Twin Pass has been with us for a while. However, we've become more cognizant about how dual lumen catheters can be quite useful. There have been newer generation dual microcatheters such as the Sasuke, which has a tapered tip similar to the Caraval, allowing it to improving the crossability, and the over-the-wire exit port for the second wire has been moved closer to the tip. Similar changes have been adopted in the in the Twin Pass torque. This is an example of where classically dual lumen catheters would be useful in accessing branches beyond the occlusion. This is a CTO PCI of the RCA. The challenging aspect about this case is that there is no good distal landing zone. The best landing zone is in the posterolateral branch. If we could get a wire down there, we can probably deploy a stent there with reasonable result. We had to go retrograde via the PDA, starting a knuckling maneuver. We were ultimately successful in doing reverse cart, but we're still not done. Our externalized wire has gone through the PDA branch, through the PDA, and we want to send it to the posterolateral. So to access the posterolateral branch, we take a twin pass over the externalized wire and the over the wire port, and then through the over the wire port, we advance the workhorse wire and secure access into the posterolateral branch. We then remove our externalized gear and stent into the PDA, in the posterolateral, and get a reasonable final result. More advanced techniques using a dual lumen catheter to stabilize the wire to cross into side branches. Single lumen catheter does not provide as much support when trying to wire into side branch as a dual lumen catheter would. This is demonstrated in this video where a single lumen catheter is being used to try and wire into a side branch. And what's striking here is the amount of flick and wick and movement of the single lumen catheter. Compared to a dual lumen catheter in which a wire is advanced down the main branch, you can see now that the microcatheter is quite stable and secure, providing good support. Parallel wiring is now making a comeback. If a first wire goes into a subintimal plane or exits the vessel or doesn't track the vessel course, then using a dual lumen catheter over that wire and the over the wire port, sorry, in the rapid exchange port allows advancing a second wire in the over the wire port and increasing the chance of success. Guide extension in the CTO field has been challenging. Classic guide extension catheters such as the GuideLiner or GuideZilla are challenging to use as they make trapping very challenging. The TrapLiner is a combination of a guide extension and a trapping balloon, overcoming that difficulty. In this case, we had a wire down across a very calcified lesion. We weren't able to follow with the microcatheter. Using a TrapLiner, we were able to advance the microcatheter enough with that extra support, allowing us to advance a rotowire and perform rotablation. This case exemplifies where a TrapLiner is extremely useful. This is not a CTO. But when trying to wire the lesion, the wires entered the subintimal plane. Parallel wire was attempted, unsuccessful, and now we've lost distal flow down the LED and the patient is starting to develop myocardial infarction. We felt that the best way to salvage the situation was to do ADR using a Stingray balloon. We have 6 French gear, and using a 6 French TrapLiner, we're still able to deliver a Stingray balloon down the vessel. More importantly, a TrapLiner is important to prevent subintimal hematoma formation. Subintimal hematoma forms when the subintimal plane is exposed to systemic blood pressures. The TrapLiner can block the inflow and tamponade the subintimal plane, preventing this formation. You could still do this with a regular guide extension, however, then you would have extreme challenge in trapping the the Stingray balloon in and out. We advanced the Stingray balloon to what we felt was a good entry zone. We advanced the twin pass as much as possible to block the inflow to the subintimal plane. We did a blind stick and swap with a Stingray wire followed with a Pilot 200 wire. It was moving in a way where we felt that we were probably in the true lumen. We were able to confirm that with the workhorse wire, finding several branches. And we're able to stent the LED, aborting the infarction. So in conclusion, newer iterations and evolutions of CTO equipment have occurred in recent years, and networking is key to keep informed of equipment updates and their role in improving your procedural success rates. If you do have any questions, please do not hesitate to contact me.